Hi, Vikas. Hi, Vikas. Can you hear me?
Yes, am I audible and
Yes,
am I
yes.
visible,
Hi,
sir?
hi. Waiting for your video to come.
Perfect, sir.
Okay, great, great, Vikas. Okay, so just give me a minute. We'll introduce and we'll start. I'm not sure if you have attended any of our talks before, but we are very happy to have you here. And it's amazing how good the TMH alumni is that you agreed to take this talk for Joydeep in just the nick of the time. And it also shows how well prepared you are that you agreed to do this for us. Thank you so much, Vikas. So we'll just do a formal introduction and we'll start. So it's already 8:33. Okay. So just give me a minute. I'll start the recording. Are we live on YouTube? We're live. All right. Good evening. It's Wednesday 8:30 and it's the Cancer Academy time. After a short break of a week, which we took ourselves last week, it was not forced upon us, but we felt that we needed that break. I'm sure that you people are all jarring to go about it, but we felt we needed to do the break, and Diwali gave us that wonderful opportunity, excuse basically, to seek ourselves Wednesday away. But it is something that is very important for us that it continues, and it should continue in a format which interests all of you, which interests the faculty, so that the momentum keeps on going. And with in line with that, we chose a topic which was not just academically important but also clinically very relevant, because this is something which we all come across as oncologists in our practice day in and day out. And we thought that instead of asking a surgeon or a radiation oncologist to actually talk on this, why not get a medical oncologist to talk on this? Because the surgeons at least have this grudge with medical oncologists that, when it's a MUO, why is it that we were not consulted? But we did not specify MUO to the neck or something else, but we defined it as just as an entity to make it a broad-ended topic, and to look at how a normal oncologist would approach a case of MUO. And our subsequent class would be in continuation, where we'll take one pathologist to talk on immunohistochemistry. We'll have a radiation oncologist talking on the planning of radiation for a MU in the neck, and so on. So this is a chain of topics that we are starting, and we are very happy to have with us Dr. Vikas Talreja, who will be talking about how he would go about working up a case of metastasis of unknown origin. Like I said, it's not defined where the metastasis is from, but it's just a spot somewhere which has been picked up by somebody and referred to Dr. Vikas. I am sorry to put Vikas in the spot that he had to take this class on a very short notice, because Joydeep, being a very good friend, he was not able to join us today, and he himself asked Vikas to do this, and we are very thankful to Vikas to consent and come on board at a short notice. Vikas has been alumni of TMH Medical Oncology. He is a DM, and very recently he was at Safdarjung Hospital as the medical oncologist for the biggest public hospital, that is Safdarjung Hospital, and has recently shifted to Kanpur at Regency Hospital. He's a very dear friend, and I invite now Vikas to share his screen and start his discourse. Vikas, me and Dr. Geeta there on the standby. We have 38, 40 members, and it keeps on. It peaks around 8:50, where we'll have around 50, 55. We have this parallel running on YouTube, so it stays recorded. So whatever you say and will be held against you in YouTube and in virtual reality. So, so the stage is yours. Thank you, Vikas, for doing this.
Thanks a lot, Dr. Shubham, sir. It has been a very kind introduction, and I feel very privileged to talk about a topic that is very, very dear to my heart. Thank you, Dr. Joydeep, for giving me a topic that is that much close to my heart. And it is being close to every medical oncologist, every oncologist, because it is a field that distinguish us from other people. So we come across a lot of this dilemma throughout our career, throughout every day, or in our daily practice, when we see these patients uh, with with a diagnosis of carcinoma of unknown primary, and we mind our heads, and we bend our all sort of gray matter and sulci and gyri, and to find out what could have been the thing which we could have missed, what could have been the treatment we could have given. And I work as a medical oncologist in Regency Hospital, Kanpur. And to start with, carcinoma of unknown primary is a clinical syndrome that includes many different cancer types and accounts for approximately around 2% of all our cancer diagnoses. 75% of them, unfortunately, are the post-mortem examinations, when you find out that patients has been evaluated for all sorts of things except for the carcinoma, which was found in a post-mortem thing. Most of them are less than 1 centimeter in size, and biological mechanisms are varied and also unknown. And to specify a definitive molecular signature, it is not easy and it is not characterizable. So the first step which we took is always a detailed and a complete medical history, including what were the toxic habits, whether he or she was being operated. Many times we tend to forget whether or tend to neglect this part of our examination. A patient who has been operated for a cholecystectomy, whose his HPR nobody knows, and we tend to overrule that thing. A patient who has been operated for some uh, a tonsillar lesion that has been operated, and the HPR again has not been known. uh, uh, Many times piles and other stuffs that has been operated, and still we don't know what the HPR is. And that's why that medical and surgical history is very, very, very important. We should be very, very careful, especially to enlist all the surgical histories that has been done in these patients in the past. However it might trivial it sound to be, but it does play a very important role at the end of the day, when we tend to elucidate what could have been the cause of this unknown primary metastatic cancers. The previous neoplasm is always a important history, because you always tend to find the recurrence, you always tend to find a new diagnosis. The previous treatment plan always has a etiological role of being a recurrence or a second primary or a therapy induced neoplasms also. And nonetheless, the basics of medicines that has stayed all through the century and will always stay in the next 100 years also is the physical examination. We tend to always do these examination, and yet then most of us tend to recapitulate that we might have missed that or this. So testicular examination in males is doubtly one of the important investigation that we should be doing for all our patients. Many times we have come across that in the second and the third visit, we remembered we didn't examine the testes, and there were uh, the germ cell tumors, there were the testicular lymphomas, and there were a lot of other hidden diagnosis in between those bands. And especially for the females also, the breast examination, the pelvic examination, the PV examination at the first visit is very important. It establishes not only the doctor patient rapport, but also a very important finding in this paradigm of metastasis of unknown primary. Head neck examination doesn't only include the oral examination and the nasal examination. It also includes, I believe, the Hopkins, which we should be doing for most of our patients on a regular basis, because there are those unhidden pearls that we would have missed if we wouldn't have put that scope inside, which is very simple and very easy to do. And then yet again we find that we are not doing it on a routinely basis for all our patients on a regular manner. Then comes the investigations, what we should be doing as a baseline. The complete blood count is again an important investigation. We should be not only specifically saying the complete blood count, but the peripheral smear examination also is a very important step that we should be doing for all our patients. The liver and the kidney function test again then forms a very important basis for our um, finding out whether not only for the prognostication, not only for therapy consideration, but also for uh, whether it's a tumor lysis associated or not. The LDH gives us a pseudo marker of how much is the activity of these cells. A leukemia cells, a lymphoma cells with a high LDH shows that these are very high proliferative tumor, invariably reflecting the chemosensitivity of that. And the serum electrolytes, the calcium, the magnesium, the phosphorus, all of these uh, not only directing us to the tumor lysis syndrome profile, but also invariably the clinical management, because at the end of the day, the therapy which we have to give is a holistic care. We don't just have to give the chemotherapies, we don't have to just give the radiation, or we don't just have to operate. It's the complete here, the complete performer that we have to manage. We have to manage the elevated calciums, we have to manage the elevated phosphoruses, we have to manage the low sodiums. That again are separate topics which we will be discussing in future, but right now they form an important baseline investigation, because that gives us a holistic important supportive care management that we are going to deal with it. Many times we find that these tumor markers, in males PSA, in females CA125, CEA, CA199, they tend to tell us a direction among the ocean where we are heading to, and it gives us a small um, clue. Many times when we see that in bilateral ovarian masses with CA125 not that much elevated and CACA199 quite elevated, the GI focus is always and always there, because there might be an underlying Krukenberg that has there, and burnout primary that has been there, and that's why this is a very important investigation, I feel, because then instead of directing our whole and soul to the ovarian primary, we might direct it to the GI primary, and there it lies a lot of time. These tumor markers important. Yet another tumor marker that needs to be established, and that has um, made a whole change, that we don't even go for biopsies, is the AFP and the beta HCG. AFP for the germ cell tumors as well as the hepatocellular carcinomas. The sensitivity of these markers have been so much there that we can even avoid the biopsies and start the treatment ASAP for many of the germ cell tumors with choriocarcinoma like picture, or a hepatocellular with a radiological picture with an AFP elevated. So that these slide does show a very important first step, the first visit to the patient to us in in deciding the whole treatment for the next few months that we are going to take for them. Then comes the investigations that we need to find out. We tend to say the CECT thorax, abdomen, and the mammography for females, especially over the 45 years of age group, because we tend to find out radiologically where it is there. The PET scan, no doubt, helps in 33% of our cases, especially for those with the squamous cell carcinomas. We tend to identify whether the patients are for a definitive local treatment, or we can they are a metastatic situation which we are dealing with it. There is a concept a triple scopy. When you find the neck node mass and you don't know where the exact primary is, you tend to do the three investigations of going through the nasopharynx, going through the bronchoscope, and going through the upper GI endoscopy. And they tend to upstage or tend to localize the disease at least in 20% of our patients. As I told in the previous, with the elevated tumor markers, you tend to find out the upper GI and the lower GI foci. And many times we have found an occult primary hanging in there with just not even being visible on a uh, ma- radiological investigations. No doubt the physician hands are very sensitive, but again, we tend to confirm our findings with definitely a testicular ultrasound. If there is a finding that you are not sure of, that you have a suspect of, do confirm it, because there are many times small microlithiasis, a foci of cancers inside those testes, and that needs to be very much elucidated. Transvaginal ultrasound again is a part and parcel of our PV examination, and that helps to corroborate the clinical findings that we have. And the breast MRI in those where young females, especially where the mammography is not that much helpful, and we tend to think that there are masses, and that's why that investigation has become in part and parcel of our breast findings. Now, when we go for the biopsy of that mass, most of time it comes out to be carcinoma. And when we have to divide them, the carcinoma can be divided into an adenocarcinoma, a poorly differentiated carcinoma, a squamous cell carcinoma, or a neuroendocrine tumors, because these are the most common histologies in terms of the incidence of the findings of them. There are other sometimes the IHC, and that's why, because only identification of a malignant cell is not sufficient, because your whole treatment is going to change based on what the IHC tells us. Is it a melanoma, is it a lymphoma, is it a sarcoma? And we have the various IHC markers that we will discuss in next subsequent slide, as what gives us a characteristic as where our direction of treatment and direction of management is going to head on to. So it is a very simple thing that all the pathologists do when they find out that there is a carcinoma, there are malignant cells inside that biopsy, and they do a CK marker for them. So CK is a cytokeratin, it's a pan marker, and it tells us yes, it is a carcinoma. The next thing is they put out is a CK7 and a CK20. So when both of them are positive, that means that the tumor is either in an upper GI and tract, or it's a pancreatic, or it's a urothelial tract. When CK20 is positive, it's highly specific for colon and Merkel cell. When CK7 is positive, it is not that much sensitive. You tend to find out it's breast, ovary, lung, endometrium, thyroid, and then you put out other markers, especially the TTF, to find out the other sources. When both of them are negative, then prostate and hepatocellular and adrenocortical are there. So these two markers alone is the first test as a reflex. If the CK is positive, it's a carcinoma. You see a CK20, and then you know that it's an colon. When you see a CK7 and 20 positive, it's an upper GI, stomach, pancreatic. And when you see both of them to be negative, it's a prostate or a HCC, and then you tend to collaborate with the clinical findings. The next marker they've put when the other are negative is the CD45, which tends to direct us towards whether it's a lymphoma or hematological malignancies. The S100 gives us a direction towards the melanoma. Neuroendocrine tumors are sensitive, and they are only positive for the synaptophysin and chromogranin uh, markers. And if they are uh, positive, your anxiety and your apprehension and your palpitations are definitely relieved, because you know the diagnosis that it's a small cell cancer, it's a neuroendocrine tumor. And that's why the IHC is very, very important, because three-fourths of our patients, 60 to 64-7% of our patients, tend to get these diagnoses only by the IHC. A very simple test, and then you have to find out what the primary is. These are very specific primaries, and they have a very specific markers to it. So with an ovarian masses, you see a PAX8 positive, that clearly gives you a PAX ovary cancer diagnosis. With RCC and thyroid, you have a differential of being a PAX8 positive. Many times you find out that there's an ovarian mass and then the PAX8 is negative. I would definitely suggest them to go an upper GI and lower GI, because then again you tend to find out those masses there. TTF1 again is adenocarcinoma lung, and you tend to find out that there. The second is the thyroid, where it is quite common. The napsin is again ovarian with a clear cell variant, a lung, and a papillary RCC variant. Breast, if you have to be there, it is there. The GATA3 tends to help you with that, and the ERPR also tends to help with the diagnosis. Then again is the colon, where you see most likely the CDX2 is positive. The P63 and CK5 and 6 are positive in squamous cell carcinomas. In thyroid cancers, the thyroglobulin, and in papillary cancer ovary, again the thyroglobulin is positive. For hepatocellular carcinomas, the arginase and HEPAR are the specific test, and for prostate, PSA and NKX3 are the specific test. For the adrenocortical carcinomas, these are the inhibin is the specific IHC marker that has to rule out. With the clinical, radiological, and the histopathological profile, these markers are just confirmatory that when you put them, you tend to get the diagnosis. So first step is definitely the history. Second is definitely the investigation, um, the examination. The third is the investigation, and then with the confirmation of the malignancies, you tend to find out these primary sites through them. Now, another concept was the gene expression profile of these patients. There are various platforms for it, and it has been available for over a decade and has stayed there. The cancer type, the biotheranostic one, is the 92 gene panel, where they put 92 gene RT-PCR assays and tend to find out the localization of what is to be the primary of it. The cancer origin, the Rosetta Genomics panel, has a 64 microRNA gene expression level test. What these tend to say on a molecular profile, where is the primary carcinoma of the origin, and they most of the time also have a very good sensitivity of 85 to 89% of them. And when you compare whether the IHC and the molecular, both the trials where the pathologists were blinded to the tumor types and performed the IHCs and compared them with the molecular test, both the studies said that the molecular tests were much more accurate. The differences were accentuated when the tumors that were poorly differentiated, that is 83% versus 67% in a poorly differentiated carcinomas. These are the papers where it says that even though you look at those patients with a histological diagnosis of predominantly what the normal profile is, the adeno, the poorly differentiated, the squamous, neuroendocrine, and then you tend to find out what are the various primary origin of these tumors through the molecular profiles they have put it on to. Now comes what could be the role ahead where we go it. If the anatomic site is determined, we have to treat it as per the primary site, as most of the cases in them the anatomy is determined. We took out the histopathological diagnosis, we put the IHC markers, confirm it, and then do the site specific treatment, which includes whatever the drugs is. We need to put out an additional IHCs also to find out what the sensitivity of these drugs is. So suppose it comes out to be a lung cancer, adenocarcinoma, you put out the EGFR, ALK, ROS, NTRK, BRAF, HER2/neu, and so forth and so on markers. It comes out to be breast, you put out ERPR, HER2/neu, PDL1, and so forth and so less. Just because not only the diagnosis is important, because you also need to find out what could be the best suitable targeted therapy for these patients. When the anatomic primary site is not detected, as in 2 to 3% of all these patients, you take out those which are overtly visible to you of an appropriate lesion, put out those IHC, put out the molecular profile, and you tend to get your diagnosis. And if again doesn't go as per the uh, majority, in 5 to 10%, where you don't tend to find out
9 बजे कर लेंगे, ठीक है?
whatever the best it is, you put them either on an empirical chemotherapy or on a clinical trial. Whatever be the best traditional first line chemotherapy, the response rate hasn't been that much good, with less than 40%. If you put them on an empirical chemotherapy with a paclitaxel platinum combination or a gemcitabine platinum combination or a vinorelbine combination, with a 2-year OS of around 20%, with a median overall survival of 11 months. But that's only the half side of the story. With new molecular profile, with new molecular targeted therapies. There has been a basket of uh, uh, clinical trials. There has been a basket of a lot of treatment options, and irrespective of we get or we don't get the diagnosis, but yes, the targeted approach is always there, and you tend to find out the best possible treatment for these patients. And that's why the site specific approach a prospective trial was done at a Sarah Cannon Research Institute, where they did a molecular gene expression profile to predict the tissue of the origin and also to direct the site specific therapy in patients with carcinoma of unknown primary site. And with 289 patients, with 252 of them were being successful from or localizing what was the primary site, and 247 had the tissue of origin among themselves. So the sites were biliary tract in 18%, urothelial in 11%, colorectal in 10%, and in 7% it was non-small cell carcinomas. Out of these 252 successful patients, 194 patients were underwent the treatment based on the site of the origin, with a median OS being around 12 and a half months. For more responsive sites, 13. So that was the difference of giving a site specific approach. Median survival was 13.4 months as compared to the 7.6 months, respectively, with a significant p value. When a subsite is identified with a molecular assay, specific markers are given. You tend to localize a much better tumors, and then you tend to give a targeted therapy to them. Then it does make a difference in the ultimate outcome. So you tend to find out HER2/neu in breast, colon, stomach, the EGFR, ALK, ROS, NTRK, BRAF, PDL1, MSI in lung. Again, the KRAS, NRAS, BRAF, MSI for colon. For most of these tumors, you also tend to do an additional PDL1 test. In head neck, also, you tend to do a PDL1 test by a combined proportionate score. And then you tend to find out their sensitivity for the immunotherapy, which can be elucidated for this. Another molecule that has gained quite a lot of attraction over the past few years, especially in carcinomas of unknown primary, you tend to do uh, a TRK fusion, and then you find out among them if they were positive. For those who were positive with the TRK fusion protein, you gave out the TRK inhibitor, that is larotrectinib, also known as commonly by the LOXO 101, which is a selective tropomyosin receptor kinase inhibitor. And you could see that out of 100, 78% responded. That gives us a very much response. And these are some of those patients who have been relapsed refractory, and they many in multiple lines and previously treated. And then you find out only with a pill you can get a 78% response rate. That again is an amazing development. The median duration of response wasn't reached, as majority of the responders which were responding were keep on responding, and they were on without progression. In fact, the longest responder remained on treatment at 23 months. 8% patients had a response of more than a year, and 16 patients are more than of a 6 months. So all of these tends to give us in a direction that yes, the molecular therapy is the new sun here, and it's all going to change over the next few years with a more and more molecular for it, says there. And then comes the role of the PDL1 MSI, which I told was that when they tend to give us a direction whether the immunotherapy which you are going to offer them are going to be a benefit or not. So if the MSI is low, um, the MMR is deficient, then these patients tend to, sorry, if the MSI is high and the MMR is deficient, they tend to have a sensitivity to immunotherapy, and the response rates are proportional to the MSI instability. That is, the higher the MSI instability, the deficiency of MMR pathway gives them a predilection for an immunotherapy response, and you could see for those who had these, there was 40% who responded as against those with an MSI stable or a low or an MMR proficient pathway, where none of them responded to the immunotherapy. Similarly was the 5-month PFS, where the MSI high or the MMR deficient were responding in 78% of patients at 5-month interval, while those with an MSI low or stable and a MMR non-deficient or a proficient, only 11% responded. So that's the end of my slide. I thank again Dr. Shubham and the whole team for giving me an opportunity, and would love to take any questions if there are any.
Thanks, Vikas. It's a really crisp presentation, but it raises some of my doubts, which I'm happy that I'll ask you, because this is what we come across in clinical practice is that when we talk of metastasis of unknown primary, it would usually start with, it could be a lymph node in the neck, it could be a met in the lung, it could be a lesion in the liver. Okay, these are the three most common things which comes to your mind when you start thinking of, I don't know where it came from. So once a patient comes to you with any of these three things, obviously after the clinical examination, uh, suppose if it's a liver primary and it looks like a met and there is no other physical finding or a finding on clinical history that you could elucidate, would you go for a biopsy first or would you go for a PET CT? My question is that, both of us are now in a clinical practice and we are cost conscious. It's very important to get cost into this, and also time, because time is pertinent for the patient, and most of our patients now are very impatient. So they want answers quickly and they want answers to given on spot, and they put us in a spot where we tend to skip steps in workup of a patient. So it's not a bookish to talk only of steps, but to my question is, how soon would you jump to a PET CT and not get into all these tumor markers and stuff like that?
So for me, it is very important that when you look at a liver, you see it is a primary or it looks like a secondary. For whatever base, get a non-invasive test as better it is, because no doubt biopsy is definitely an important part for elucidating it, but it always comes in a third step as compared to the non-invasive. So I would definitely go for a radiological investigation. My preference would be first to do an AFP, first to do all those tumor markers upfront, and then go for the third step would be the radiology. And then if nothing comes out in PET, then probably going for a uh, biopsy, because invariably you have a lot of markers in IHC where you tend to put it onto. Um, so all of these would be very efficient at the end of the day to confirm. So biopsy is the confirmation test. All of these are other the staging investigations. So that's why we need to first of all do what is necessary to find out, is it only the liver that is being affected, whether there is a lung mass, whether there are breast masses, whether there are other masses that are there. And then at the end of the day you have a selective stains, because um, whatever the best biopsy you do, I would be more conserved on not using it on a the IHCs for diagnostic purposes. I would be much more using my tissue for a molecular purposes. So just to give an idea, many times what we see patient
So,
getting an
so
ultrasound and you find a liver metastatic. I would definitely ask them to get a CECT thorax along with the tumor markers. And if there is a lung mass and there is a liver uh, metastatic to suggestive of metastatic to it, I would ask the pathologist not to waste on the other CK7 lymphoma and the markers. Use that tissue for a molecular testing so that I can direct my therapy towards it.
So if I get you correctly, Dr. Vikas, you will confirm whether it is metastatic or not, by imaging, imaging characteristics, probably an ultrasound, because that is how the mass would have most likely been detected on a ultrasound or a CT scan. So you'll confirm whether it's looking like a metastatic or a primary to begin with. You will get the tumor markers, which is again a non-invasive test. Then probably if you are not able to spot a specific primary, you will go for a PET CT scan first, which will give you the uh, likely area to look into, and then you will go for a tissue diagnosis. And you want to stress on the fact that you would want to preserve that tissue for molecular analysis and not waste it on having a battery of IHC. You know how we go about it. You get 4 IHCs done first. When it confirms it's a carcinoma, then you have another 4 set of IHCs done according to age and sex of the patient. And when that 4 fails, then you have another 4 set, which I agree depletes the tissue. So that is what has to creep up in our workup, that we have to give importance not to the IHC but also to the molecular testing. And when tissue is scarce, we have to ensure that we optimally utilize it. So that is one thing. Dr. Geeta has pertinently asked a very important question, that what would be the role of liquid biopsy in uh, a case of MUO? Suppose you are unable to reach a diagnosis with the IHC, they just with the biopsy, they just tell you, and most of the times it happens, they just tell you it's a poorly differentiated tissue tumor. Then how would you go about it, and when would you consider getting a liquid biopsy?
So 5 years back, again, I would have said that no, I don't think so that's much a role. But over the years, when I've practiced and I've seen, liquid biopsy has evolved a lot. So we started with probably only for a liquid biopsy, we did a concordance for the EGFR thing, that if there is a present of the EGFR mutation in biopsy, it's also present in the blood. But over the years, what we have seen, the Roche, the other platforms, the core, they have developed the Cardant and the foundation. And what they have collaborated is, and they have recently got an FDA approval for it also, that no matter how much tissue we take it out, it's going to be at the end of the day sometimes insufficient. So we have to find out a alternative method, and liquid biopsy does it. So if there is an in liquid biopsy a mutation is detected, it is definitely, we give a targeted therapy to that, and it does have an implication in the survival of the patient. Many times in biopsies we don't find those EGFR, ALK, ROS, PDL1, NTRK mutations, but in liquid biopsies we tend to find out, and there comes the role of liquid biopsy. So I believe that liquid biopsy is a very important tool for those patients who have an affordability, and where the biopsy and the tissue is a issue, and it does definitely has an important implication for all our patients, especially in the lung and the GI. The liquid biopsy has definitely changed the management over the last few years.
Okay, so liquid biopsy is not the first thing to do, but you will actually do it when tissue is an issue, and you will reserve it if there is no issue. Okay, so there's a couple of questions which are very chemo sense specific questions by Dr. Parmod, and I'll take them in a little while. Dr. Nidhi is asking, just like we discussed about the liver cup, how about if it's a adenocarcinoma of a neck node? Okay, if you find a neck node and you find it's looking on a FNAC or in a say a biopsy, they tell you it's a adenocarcinoma. How would you approach it? I mean, other than clinical examination and the clinical history.
So an adenocarcinoma of a neck, will definitely be a mind-boggling thing for everybody of us, because if it would have been a squamous, I would have definitely think of an head neck primary. um, we tend to then find out by radiological investigations that is the salivary gland being a tumor. We tend to localize through the triple endoscopies whether it has been coming from which site it is there. And then we tend to find out what is the uh, tumor profile of it. So many times you find out that the lung primary going to a neck, where many times upper GI primary going with an adenocarcinoma, or it's a salivary gland tumor. So that's how you approach. You do a radiology, and then you tend to find out where it is going towards, and then also the upper GI endoscopy and the bronchoscopy for these patients, as depending upon where the radiology gives a direction to.
Okay, so I'll just pack it up better for Dr. Nidhi. So I would say that as a surgeon, we will look into the level of node which is involved. If it is level 1B, 2, then the most likely the site of origin should be somewhere in the head neck region itself, and probably you look into the salivary glands per se. But if it is in the lower neck, level 4, level 5, then you will start looking at probably a infraclavicular organ, to be very specific. If it's a female, my first doubts would be towards breast, ovary, colon, and I will ask my history in that order itself: breast, ovary, and colon. And colon, I mean GI. Breast, ovary, and then GI. It could be a stomach, it could be a colon, it could be a gallbladder to begin with. If it's a male, probably I will look at GI more likely. And then obviously male breast is something which we always do not give much importance to, but it is something that we should ask. Lung is something that we should always consider. So it is very important that we define the level of the node when we are saying that we are suspecting a neck mass. So that is why it is important. Your clinical examination is directed in that order, and again your tumor markers are also directed in this order. Dr. Pramod has asked, and this is a chemo specific question, that if you're planning empirical chemotherapy, then among paclitaxel with platinum versus gemcitabine with platinum. So you have a common platinum with either paclitaxel or gemcitabine. Which one has largest data? Point one. And does grade of tumor make any difference in selection, especially if you are unable to differentiate between SCC and ACC?
So I will answer these questions in a series. The first taking what the data is. So the data is actually an analysis of multiple trials and multiple studies that has been done, and to select probably the paclitaxel carboplatin or the gemcitabine platinum combination. There is not a drug. It's not a level one treatment which you can give, but yes, the data has been slightly tilting over the taxanes platinum combinations in view of a better response rate and a tolerable profile. Now, why is that so? Probably that has been a bone of contention for, because not many Indian studies are included in that, and that's why the gem and taxane, the platinum combination hasn't performed, because the Western literature is probably towards the head neck data, while the Indian literature must be pointing over towards the biliary data. That the data in the biliary tract hasn't been that much of there. So I would say that the best thing is to localize the primary site. If it's not being localized, then to go on by the clinical examination, radiological biopsy pattern to find out what could be, it's a above diaphragm or it's a below diaphragm, thing. So for above diaphragm, I would prefer a taxane and platinum combination. For a below diaphragm, I would prefer a gemcitabine taxane platinum combinations for it. And I don't think so it going to be a level 1 indication for next 10 years also, because it's the biology that governs our decision for it. And if the tumor, the grade is not there, or probably, sorry, if the differentiation is not there between a squamous and a adenocarcinoma. So what we did, I will let you know, we have, it's on the verge of publication right now, the molecular profile of the salivary gland tumors which we did. And we tend to found out that many of time these are very low grade tumors. So if you find a grade 1 tumor, uh, and patient is asymptomatic for it, I would definitely observe these patients, because um, they tend to have an implication on the treatment decisions. So when we did the molecular profile of these salivary gland tumors, and then we found out that um, just like in breast cancer we have a visceral crisis like situation, similarly in salivary gland also, if there is an end organ damage, then only is the indications for the chemotherapies. uh, Otherwise there are a large number of tumors in the salivary gland where we can just observe them, and we can treat them without affecting the survival, uh, based on the grade of the tumors.
Sorry. Okay, so also I think that it is always going to be a high grade tumor if they are not able to differentiate between SCC and ACC, because heterogeneity of the tumor and how bad is the morphology actually decides if they are not even able to say whether it's SCC and ACC. So that is one thing. Dr. Nidhi also asked that is there any role of anthracyclines in cups? We have been talking about taxanes and
Yes, I
platinum,
do
but
believe, I believe that there is a role, where the role is probably only in the terms of breast. So if you tend to think that yes, uh, the tumor is looking like a breast primary, then probably where the role is in of anthracyclines. Otherwise, I don't think anthracyclines are an important first line treatment for this regimen, at least as a uh, first line therapy. I wouldn't give that right now.
okay, okay. So, Vikas, we have talked about a liver nodule and its workup. We have talked about a neck nodule and its workup. Let me ask about a lung nodule, okay, which looks like a Met. Okay, radiologically, it has come to you. Now, what we are getting a lot of CT scans done for COVID and post-COVID follow-ups. And if somebody comes up with you with a speculated nodule, which is looking like probably not a primary but a Met, how would you approach it then?
So definitely the sequence remains the same. The clinical regarding the past, what was the primary that has been treated, osteosarcoma or a bone tumor or some other tumors that has been operated. Then again, any other operations that has been done for other reasons that is to be ruled out. Again, definitely go for probably uh, the PET scan to find out, is it the primary, or is it probably something uh, that has come from any other organ. At the end of the day, depend upon where it is, the location is. If it's in the periphery, I would go for the biopsies. If it's in the central region, I would definitely go for the bronchoscopic guided biopsies, for the confirmation and for finding out the tissue of the origin for it. And definitely, if it's an adenocarcinoma, I would say that yes, I'm rest assured that it is the primary origin of that. But if it's then squamous cell carcinoma, I would again scratch my heads back to again, as it could be a primary or it could be a secondary from any other organ.
So what if you do a PET scan and you're not able to find any other site of metastasis? You will consider it to be the primary most likely, and you will then, and if it is the only site and if it's operable and the patient is physically fit, would you consider for a wedge type of resection or a complete lobectomy? Why I'm asking is this, because if it's a wedge, then you are taking it to be met kind of thing, and you're just offering a R0 resection, whether it's you are offering a lobectomy, then you are telling it that we are considering it to be a primary lung disease.
So again, putting my foot into my mouth again, but then yes, I will. I know I am being recorded, but I will definitely ring up my dear thoracic surgeon, Dr. Shubham Garg, in the middle of the night for the same, and I would say him that get me the lobectomy, because all my clinical examination, radiological profile is not helping me out, and with all these things, there's a periphery lung lesion. It might look like a met, but then again it is right now as it is. So the best thing is to go and to take it out with the oncological principle of considering it as a primary. So that would be my message
So
for.
basically, what we are doing is we are giving the benefit of doubt to the patient that we are considering that it's not a stage 4 disease where the disease has come from somewhere else, but it is probably a primary, and we are offering you the best treatment. And that is why, obviously, the patient has to be in confidence that we are telling them why we are doing that. And also, the patient has to be fit for withstanding the procedure. Okay,
Yes.
okay. So, what we have not yet discussed is, suppose now again, so I am just going through all sites of cups, Vikas. Now, suppose if it is a bony lesion, if it's a bony lesion, and I am not specifying whether it's lytic or sclerotic, but if it's a bony lesion in a 60-year-old, suppose female, why again I'm not going into males because I know the horses will start running for a prostate. But suppose if it's a 60-year-old female with a bony lesion, how would you approach it?
So again, I would say that the clinical examination after that, very important investigation that I definitely do for all my 60-year females are again myelomas workup. So you tend to do the serum protein electrophoresis, serum immunofixation, and the free light chain assays, because many of these myelomas are very aggressive and
Because we lost your audio.
uh, because it could be myeloma or it could be a non-myeloma matters, and they help us in a lot of our uh, treatment decisions, because I know the biopsies are very tedious, because and most of these biopsies I don't tend to get the molecular profile, because when you tend to do the decalcification, there's a lot of process that goes on, which ruins the molecular uh, tumor profile of that patients. So definitely the tumor markers, the CA125, CEA, CA199, as well as the serum protein electrophoresis, the myeloma profile, and probably uh, then go for the biopsy to find out if all previous were negative, to find out what could have been the reason for that.
So bone biopsies are actually not all that easy. These are the ones that we actually don't want to get into until unless they have a good soft tissue component. So probably a biopsy comes much lower down in a bony lesion. We would, have a lot of second thoughts before we are considering a bone biopsy. But I agree with you that this is why I wanted to get a bony lesion, because then the myeloma comes into the picture. You start thinking in terms of myeloma, and again you have this set of tests which you will not do normally, but the electrophoresis, the Benz Jones proteins are something that you will do. So a last scenario, Vikas. Now, suppose if this was a node in the retroperitoneum, which is around 2.5 centimeter, okay, and let me get a PET done already for you, where there is no other uptake, but uptake only in the a node, and some other nodes around it, and it's a significant node, 2.5 centimeter. How would you approach it?
So sorry, the node is in the neck.
No, retroperitoneum.
Okay, a retroperitoneal node. And we do have a biopsy confirmed for it,
No,
or
we
no?
don't
No.
have a biopsy yet.
So again, I would ask my GI surgeons to go for an exploration, possibly a CT guided biopsy first, if it is feasible, if it's not encasing much of those dangerous vessels, because at the end of the day, we have to remember that first thing, it could be tuberculosis for all reasons in India, because that's a very important differential that we tend to rule out. The second thing again is an important, as I said, is um to do those tumor markers, because here comes the importance of those AFP, beta HCG, LDH, the testicular uh, germ cell tumor markers, because most of them presents with these asymptomatic lymphadenopathies, retroperitoneal lymphadenopathies. Again, the third thing which I would do here is I would definitely look at the LDH levels, because again, if it's a lymphoma, they tend to rise. The tumor lysis profile of the patient, the electrolytes, the calcium, magnesium, phosphorus, um, the KFT of these patients, hyperuricemia, hypercalcemia. If these are there, then again it shows that it's a very rapidly proliferating, and CT guided biopsies are usually a feasible approach, and depending upon the results, we will uh, direct our therapy to it.
Yes. So I think that sums it up in terms that you will not rule out benign pathology, especially tuberculosis, because mediastinal and retroperitoneal nodes are very notorious to harbor TB. I would also actually look into the age of the patient. Younger patients, I'll keep lymphoma probably higher on my list, but elderly patient probably not so much. They will go more in terms of malignancy, and your scopies and everything comes into the picture. So, Dr. Parmod has asked another interesting case scenario. Just hear it out. There's a adenocarcinoma in the head neck node. In the neck node, there is a adenocarcinoma which shows intestinal subtype, probably on IHC, and they are not able to find any GI primary on Scopy uh, and on PET CT. So how would you approach it? So basically, it's an adenocarcinoma of the in the neck node, in the cervical node, with no possible primary on PET and Scopy.
Again, in head neck adenocarcinoma, I won't uh, be doing, but at the same time, many of these patients, what we do is a molecular profile. So I would definitely ask him to get a ER, PR, HER2/neu, CKIT, and EGFR. Uh, these mutations done on these, so that it gives us a direct to where these tumors tend to originate from. And definitely I would ask my surgical colleague for if this is for a definitive resection, or uh, if it's for a definitive treatment, um, so that we can have a more tissue and a more probably tumor profile of that patient.
So, as a surgeon, I would just want to chip in that the last non-squamous pathology that I saw in head neck turned out to be actually a very high-grade angiosarcoma. So it's not that I'm not saying that it could not be adenocarcinoma. It could be an adenocarcinoma, but intestinal subtype, if it is if this intestinal subtype is coming somewhere from the lower down, supraclav, then I would say that probably it's occult met, and I would want to go ahead with chemotherapy first, see the disease biology. 3 months down the line, if it remains the same and the PET shows nothing, then probably I'll offer surgery. But if it's somewhere in level 1B, 2, then probably I'll think about actually going for surgery first, getting the tissue out, have a good pathology on the specimen, and then deciding the treatment. Because you have to understand the lymphatics never lie. So if it's going to
Definitely.
be if it's going to be level 4 5 node, then probably it justifies us giving chemotherapy first. And again, both me and Vikas are not very experienced. I would really want to hear from somebody more experienced than all of us, but this is how I would approach it. And it's a really interesting case scenario, and probably we'll discuss it in a subsequent lecture when we have more people with us. And we will have a special on the management of cups in the neck, because it's a very pertinent topic. But usually what we deal are squamous cells, not non-squamous. So we can actually have a section on non-squamous cups in the neck. That will be a nice one. Okay, so if there are no more questions, because thank you so much for doing this for us. We made your life more difficult by throwing some really not so usual case scenarios on you. And believe me, when we make these case scenarios, we take the doomsday situation into our mind and put everything, the worst type of cases together and offer it to you. But you really played them well, and I'm sure it's a evolving thing. We all learn with experience. And let me get Dr. Geeta into it. Dr. Geeta, we were looking for some gray hair. We were looking for some gray hair. No, I'm
So
not
that's a
suggesting.
choice.
I am not suggesting that you have gray hair, but we
No, no,
were
I've
just
had it.
looking.
I've had gray hair for as long as I remember. So, um, so I used to have gray hair from this time that I was in 11th standard. So I used to have this mop of white hair, which used to resemble something like what
Indira
Indira
Gandhi,
Gandhi used to have.
yes.
And so I kept it on till the first year of post graduation, when my mother said, "Look, you're never going to get married this way." So that is when the camouflage began.
So
Yeah.
I just said that we were not referring to your age. We were just looking at gray hair, and I'm so happy that you had it from the first year. So we can still presume it you to be just passed out and happy.
Yeah.
So we had a really interesting discussion with Vikas, and I'm sure that it has opened up Pandora boxes of how we can go about with the next set of lectures and how we can do it. So,
Right.
last few words from you, ma'am.
So let's try and get, because you said we would like to have a pathologist on
Yes,
board, because, one
IHC
of the
and
areas which really baffles you is also these soft tissue tumors,
hmm,
where you could be doing n number of IHC markers and still not come to a conclusion. Because I remember reading an investigation report from MSKCC, and they had done about 121 IHC markers, and at the end of it, it was still possibly this and possibly that. So that's how, Vikas said, very, very, somewhere in those lines, I hope it was not missed, and that is, IHC is not a substitute for what you can get through morphology, because I think morphology continues to be the big thing within pathology. But IHC is something that helps you to zero in on the culprit. But yeah, you should not put morphology on the back burner. So we will try and get a pathologist. I've already written to him. He should be responding, and probably next time we will have a pathologist tell us about how to put IHC to good use in terms of a metastasis of unknown origin. Yeah, so that is what we
okay,
will do.
okay. So, thank you. So that is how our next lecture is going to be. We'll just finalize the speaker, but we'll stick on to metastasis of unknown primary. Probably it could be will be talking about radiation or probably the pathology, but that is how the next 2 weeks are going to be. Thank you, Vikas. Thank you for joining in. Thank you, everybody who joined in. Stay connected. Subscribe to our YouTube channel to get more archives of such videos. And we'll see you next Wednesday. Thank you and good night.
Thank
Right.
you.
Good night.
Thank you.